excited to have Dr. Michelle Broadhurst here tonight. Dr. Michelle is a chiropractor. She's an acupuncture. She's trained in CCRP. She treats horses and dogs. And she chose to talk to us tonight a little bit about bone healing with the shockwave. And then I'm sure there'll be time for some discussion and questions. So we hope that we can make this as interactive as possible when we finish. And have fun. And thank you, Michelle. You can do a quick introduction. You're probably better at describing yourself than I am.
Sure. Thanks, Cindy. Thanks, everybody, for being here. As Cindy said, I'm a chiropractor and a chiropractic acupuncturist, as well as a chiropractic sports physician. And then I have specialized or have a special interest in animal chiropractic, as well as being a certified rehabilitation practitioner through the University of Tennessee. So I wear a number of hats. I've been in private practice for almost 25 years and have a multitude of two-legged and four-legged patients. So what we're going to be talking about today with extracorporeal shockwave is how important it is in the role of bone healing. And for those of you that use this in your practice in this regard, I'm sure that you've had wonderful success. So we're just going to go through very quickly a couple of basic things. So if we look at the mechanism of action of shockwave itself, we know that it is all about mechanotransduction of tissue. But how does it actually achieve what we are looking for, particularly with bone healing? So one of the biggest things that it does is that it creates a cytokine induction. And this is particularly with TGF-beta1, substance P, and osteocalcin. And as you know, things like substance P is really important because it mediates the interaction between the neurons and the immune cells. And so it creates more proliferation of the cell and the cytokine production. But when we get to actual bone healing, one of the most important thing is nitric oxide and the synthesis of nitric oxide itself. So nitric oxide mediates the remodeling of the bone, and there's a whole bunch of information on this on the internet, so I'm not going to completely blow you guys away today. But basically what it does is it inhibits osteoclast activity and bone resorption, and it stimulates osteoblastic activity. So it helps to actually allow for the stimulation and differentiation of osteoblasts by creating these high doses of nitric oxide. As well as that, we've also got our nociceptors, which obviously helps to inhibit our afferent pain responses. And angiogenesis for me is one of the most important things, and neovascularization that shockwave has for me as a practitioner, because without blood flow, we really don't get anywhere and we don't see the healing that we need to see. And for those of you that treat a lot of tendinopathies, things like plantar fasciitis, myofascial trigger points, all of these things that are really tricky sometimes to heal, that neovascularization and angiogenesis is absolutely imperative in those cases. So just a little review of the biological responses that happen with shockwave. So once we have the application of the shockwave to the area, we have an immediate biological response. And this in turn releases your cytokines that creates a microcirculatory and inflammatory response, which is really important because for those of us who are treating patients, we actually need to create microtrauma in order to elicit an inflammatory response. And by doing that, we actually start the healing cascade. In addition to that, we get the release of angiogenic growth factors such as ENOS, VEGFs, and PCNAs, to name just a few. And these then increase that functional capillary density, which allows for healing in the soft tissue. And we have a BMP release, which is your bone morphogenic protein. And this is really important for bone regeneration and healing. So if anybody ever asks you how this works and you want to sound really fancy, you can waffle off those things. But basically what it does is it's a multitude of different cascades that are happening concurrently to create a inflammatory response that results in a healing response that changes the capillary density in the soft tissue, as well as having that release of your bone morphogenic proteins that results in the bone regeneration and the healing. So I wanted to just go through a couple of studies, and there are a lot. One of the biggest ones was done by Wang in 2009, and there is another fantastic study. In fact, I printed it out and I have it here because I refer to it often. That was done by Rainer Mittermeier et al., and they um, they did a fantastic study in 2021 about bone healing and shockwave. So just to give you a couple of numbers here, if you look at the screen. So in this study, they were looking at the effects of shockwave on bone healing and the systemic concentrations of nitric oxide, as we talked about before, it being really important um, for osteoblast formation and differentiation. So 42 patients with non-union fractures of the femur and the tibia were enrolled, and they were treated with 6,000 impulses of shockwave at 28 kilovolts in a single session. And what they found was quite interesting. So they saw a change in the TGF beta 1, the VEGF, and the BMP2s, as well as the serum calcium levels, because what's really interesting with shockwave is it changes your calcium and your potassium levels. And that makes a big difference too, as far as when we're talking about bone development and going basically from the outside of the cytoplasm back into the cell and cellular regeneration. That's important to keep in mind, but I digress. And alkaline phosphatase, calcitonin, parathyroid hormone before the treatment at day 1, 3, and then 1, 3, and 6 months after the treatment. So what was really interesting is at 6 months, remembering that they only had one session of shockwave of 6,000 impulses to that non-union area. So at 6 months, 78.6% had improved. So that is a huge, huge level of improvement with one single session. And in this article that I was talking about earlier about Mittermeier, they've got a lot of different, and I pulled some up to a lot of different results. And it's very interesting because most of the studies that we look at do either one session, 2 sessions, or 3 sessions of shockwave, and then generally leave it for 3 to 6 months before reevaluating. So, and in almost all of those, there was up to, I think it was an 80, I can actually check for you, an 80-some% improvement after, oh, I'm sorry, 75.5% improvement by a 10-month range. And this is when they were only done 38 were treated once, 9 were treated twice, 2 were treated 3 times with 2,000 to 4,000 shocks per region at 26 kilovolts. So that's really interesting. And to have that level of improvement at 75% across the board is really important, really, really interesting. So what they found in this study was that shockwave promoted bone healing, increasing nitrous oxide levels, as we were talking about, in osteogenic growth factors, elevating systemic concentrations of nitric oxide, and those osteogenic factors really help with the local stimulation of shockwave and bone healing in non-union fractures of long bones. So one of the ways that shockwave works with osteoblast activity is it helps to stimulate the expression of integrins on the osteoblast. And there's no test afterwards because there's lots of these very fancy words that you don't really need to understand. But what you do need to understand is that this integrin is really important because it involves the extracellular matrix in the cell. And so when you have this integrin being activated, we get the activation of focal adhesion kinase. And the focal adhesion kinase is really important because that's also what assists us in that osteoblast activity and getting that bone healing started. So there is a lot more research on that, and I can give you papers if you're interested. But one of the things that was fantastic to see is these are the studies that were done between the year 2000 and just a very small amount in 2017. And if you go through all of these and the different protocols, um, it's very interesting to see how almost every single one of them in this case, in fact, every single one of these, all improved quite substantially. And what we're seeing now, as far as research goes, is how important it is to actually apply extracorporeal shockwave at the time of surgery, because what it does is it doesn't just stimulate osteoblastic activity and prevent osteoclast activity, but it stimulates mesenchymal stem cell activity. And with mesenchymal stem cells, that is the absolute most important thing in cellular recovery that we could possibly ask for, particularly our endogenous ones. So, if we can stimulate endogenous stem cell growth at the site of incision and of surgery, there is going to be a huge healing reaction that's going to happen, and healing will happen much quicker. The other thing that they've found is doing the shockwave immediately after surgery, and then within 4 weeks, there's a number of studies that show that we get a huge improvement by following that sort of protocol. And in fact, it can reduce the healing time by up to 22% in certain cases, which is very significant in athletes of any sort, or even your couch potatoes who just want to get better quicker. So this is the article I was talking about before. If you guys want to jot this down, or you can just ask me, and I'll send you a copy of the entire paper. For those of you that really want to deep dive into the actual intricacies of the bone healing and how it all works on a cellular level and as far as markers and all of that. This is a really great paper. And it's very easy to follow. It talks about acute and chronic healing with shockwave, and it's very concise. I'd highly recommend it. So I wanted to talk to you a little bit about cases, because that's really where the rubber hits the road. Um, so this was a case we had in clinic at the beginning of the year. This is x-rays of a little Yorkie. He's 7 pounds. And when he was a year, um, he jumped off a table, and he basically fractured not just his ulna, but his radius too. So they did surgery. As you can see, his plates were in for 6 months. They took them out, and this is what it looked like. So there was absolutely no bone healing during that time. He was non-weight bearing. And so we were getting no concussion of the bone. So the surgeon wanted to amputate. And so I was approached as a last chance before this poor little pup lost his leg. And so we started doing shockwave on these areas. And as you can see, once the plate was actually removed, we've got the sites of the screws, and you can actually see the ridging in the bone and the complete non-union fracture that was still evident there. So it was very concerning, because you don't want to amputate in a little dog who's only 2 years old. So what we did is we did a protocol of shockwave once a week for 4 weeks, and we did 3,000 shocks over the area with him not sedated. So that's the beauty about certain shockwaves, is that you actually don't have to sedate the patient. So we were able to do this with a peanut butter lick pad and not much else. And he was really a trooper for his shockwave. These are his after pictures, and these were done. We started seeing significant growth at 2 months. Was his next set of X-rays. He was in the weird discoloration over here is because he was in a brace at this point. So we took him out of a hard cast that he was in, because we needed to do that in order to support the joint. And then we transferred him over into a soft brace where we were doing underwater treadmill with him, which was helping to induce a little bit of concussion in the joint, which I feel is really important for bone healing, as well as increasing the vascularity to that area. And as you can see, this has healed up tremendously well. He was discharged 3 months after we started working with him and rehabbing him. And most of the rehab at that point was just to get his functional tissue strong, and work with the compensations that he had created to get him ambulatory on all four legs. And he is a very happy, rambunctious pup who has zero limitations at this point, and we were able to save the leg. So this was a great case to really, and it really was wonderful because the orthopedic surgeons um, were all in agreement that they should amputate, but they literally gave us a couple of months leeway. And so to be able to save this leg was really a joy for both Gus and his family. And okay, so our next patient that I want to show you is Bear. Bear is a 6-year-old retriever. He was hit by a car in November 2021, and he shattered his right radius and had a severe break in his right ulnar. So he underwent surgery to stabilize the fracture, but he was completely non-weight bearing afterwards, and he had almost total disuse atrophy of his entire right forelimb all the way up to his shoulder. So again, they were wanting to amputate, and then we saw him in March 2022, which was a long time for him to be non-ambulatory on that leg. So 4 months, he didn't use it at all. And then we started with extracorporeal shockwave. We did some very basic exercise therapy and underwater treadmill. And by the second treatment, Bear was using his leg. We continued to do 5 shockwaves, but not all for the bone itself. We were doing some compensatory mechanisms too that had come up and were coming at as he started to regain some use. And he did really well with his treatments. So this is Bear. As you can see, he still actually had fragments in the bone that were completely not healed at all. So, and we had a big gap of a non-union fracture, so of his ulnar. So that was, very, very worrying at this point because he's a big dog. I would say he was about 78 to 85 pounds. So that's really large not to be able to be ambulatory. And as you can see, there's actually, even with the screws and the plate in, you can see how there's just shattering of those bones, and they never really did heal. So this is after shockwave. In fact, this was about 6 weeks after our initial shockwave, and we started to see this bone development, and then he just went on in leaps and bounds, and I haven't seen him in 6 months, so that's actually almost up to a year. So that's always a really good sign that that things are going well. So it's just really fascinating to see how beautifully the body can heal itself if it's given the right tools to do so. So I just wanted to show you guys a couple of these cases. This is now, shockwave really has become, that's Bear. Shockwave has really become my primary as much as possible for most things in my practice, because not only is it super helpful in bone healing, it's really helpful in the compensatory mechanisms that start coming up. So one of the biggest things I find, especially in non-union fractures, is the compensation on the contralateral limb in dogs, as well as they always work on a diagonal. So the opposite limb gets affected. So we often find tendinopathies happening on the diagonal or on the opposite limbs. So being able to use shockwave for all of these is really helpful because it's such a multidimensional modality that really helps with angiogenesis. It helps with tissue modulation. It changes the um, entire facade, let's say, of the body, and really makes it work together very concurrently. So that is all I prepared for you today, but we can absolutely chat about what you guys want to know.
Anybody have any questions, comments, thoughts? I know it's Christmas and we just want to be in that mode, but Michelle has had a lot of experience with this. Anybody?
I have a question, Cindy.
Mhm.
I was just wondering, Dr. Broadhurst, if
Mm,
with Gus, the first case, the
yeah.
Yorkie, would it have been better because it looked like it was still quite a mess, the leg and the bracket was removed. Would it have been better to leave that on and do the shockwave treatment?
No, I don't think that it actually made any difference. In fact, I think removing it was helpful in this case, just because it really gave the body the ability to grow into those holes that
Okay.
remained after the screws. So it was almost like a blank canvas at that point, to allow the body to heal, because we were getting no level of cytokine intervention at all to stimulate healing. So that picture that you were seeing was 6 months post of him actually having surgery. So there was no bone healing happening at all. So in order to initiate it, I think almost aggravating those particular areas was really helpful in this case.
It was beautiful. Thank you.
Yeah, no worries. One of the things that was really interesting and that I didn't mention is, when they started doing shockwave and they were using it for, the word that I can never say, lithotripsy. Um, thank you. Uh, one of the reasons why they actually found out that bone healing was applicable in these cases was they started seeing bone deposition around the ilium in these cases, and so they started. That's how it started being investigated as a bone healing portion. And for those of us who have multi modalities in our practice, I think it's really important to understand and focus in on what to use when. And for example, when I have a wound, I use my laser. Hot spots, I use my laser. If I'm doing certain myofascial stuff, I'll use a laser. But definitely for me with tendinopathies, bone healing, osteoarthritis. So I do a lot of shockwave with osteoarthritis, and I know that's not really what we're talking about as far as non-union fractures today. But for those of you that have shockwave in your practice, I would highly, highly encourage you to start using it on those osteoarthritic joints. Particularly in if you're a human practitioner, if you're looking at degenerative AC joints or even facet joints in the spine, I think it can be incredibly helpful. Um, when you're looking at dogs, hip dysplasia, elbow dysplasia, any kind of osteoarthritic issue that's going on, it's been remarkable to watch. And I'm not somebody who is I don't write tons of papers and things like that because I'm too busy practicing. But it's really interesting to see how almost immediately you are going to get a pain control effect happening. After shockwave. So I have some dogs who really struggle to walk coming in, and we do the shockwave and a couple of other things with them. And by the time they leave, they are 50 to 80% better, and they remain so for at least 3 to 7 days. Um, so it's really something that I play with a lot more with my osteoarthritic patients, and I find it really, really helpful. So I would encourage you guys to do that too.
For those non-union fractures, are you always doing between 4,000 and 6,000 shocks?
Generally, it depends on the patient. So in Gus's case, yes, we were, because we had multiple points of entry. So um, he was definitely, and so was Bear. It really depends on the injury itself, but generally, yes, yeah, I would say I hit between 3 to 5.
And then are you using, what depth are you using for the pad?
I'm sorry, I didn't catch that.
For a
Like,
piezo gel pad, for those guys, how deep would you be going?
So you don't have, it depends obviously on the dog. So if you're treating a pit bull and you're treating his femur, you're going to go much deeper because you've got to get to that focal point. If you're treating Gus, who had no soft tissue whatsoever, you're going to go very superficially. So I think it really depends on how much tissue there is surrounding that area and how deep you have to go. I know, I'm sorry, that's not a fantastic answer, but that's
no. That makes sense. I was trying to like put it in like my terms of like, are you doing this then? You said around 4 sessions once a week following surgery.
Yeah. So I do once a week for 4 weeks, and then I do a complete break, and then I re-X-ray probably. And at that point in time, because a lot of these patients are non-ambulatory, at that point we start doing concussion work and stability work and things like that. But I don't continue with the shockwave at that point. So yeah, once a week for 4 weeks, and then we kind of take a break, re-X-ray, see if anything needs doing. And in most of these cases, it's pretty much done at that point, and we start seeing really good wound healing and bone healing within, I would say, in my opinion, within 6 to 8 weeks, you're going to see a huge difference on X-ray.
Can I ask a question about everything, the examples you've given talk about the number of shocks, but what is the intensity that you're using? In other, I guess the update, whatever. Like, how do you know how strong to have it? High intensity.
So, Cindy, can you equate that to piezo wave for me, because that would be helpful?
So basically what we want to look at is, we know with the focal shockwave that you're going to get healing at about 0.15 millijoules per millimeter squared is enough to heal these things. How much energy is required and a dose response curve has yet to be done in any way, shape, or form in these shockwave therapy programs. So what we're recommending now, and what I've seen really good results, is that you want to go to their tolerance, but not make them in agony. So as long as they're feeling it, it really seems to be enough energy. And my example with that is, basically I've treated my own partner's metatarsal bones, and she was very, very sensitive, and we never got above an EFD of 0.06.
Oh, wow.
And in 3 treatments, we did 3 weekly treatments, and then the X-ray about 6 weeks later, and it had healed, and it was a non-healing fracture. So I think the hardest thing with dosing, and what we're finding is, we all want literature, which is very important. But if you're paying $100,000 or a lot of money to do a clinical trial, you're going to go on the high end with your energy, because you certainly want it to work. And I don't think we know exactly what energy we need. It's not known, and I think it's going to be hard to figure out exactly. What I say is, if you don't see any healing in your first X-ray, then yeah, you might want to try to repeat with higher energy. But I have never not seen healing with even just a lighter touch at 0.06 millijoules per millimeter squared. Is that any help?
Yes, that's very helpful. And my question is, Michelle, you're not using the piezo, right? So are you able to move it around? Can you keep it in one spot, or do you have to move it?
I can do either. So it's pretty versatile. It's on my shopping list, as Cindy knows. It's on my shopping list. But
She has lots of experience with it at all of our courses and stuff.
Yeah, I use it a lot when I teach. So that's when I steal it for a few days and get to play with it some more. I think the biggest thing when it comes to intensity is I'm not a huge believer in sedating for shockwave. I really don't, because I think you lose the magic of shockwave in that way, because the body is going to tell you what it can tolerate and what it can't tolerate. So that's very much how I gauge it. And I'm not a gung-ho practitioner, so I'm not going to kind of start it high and hope for the best. So we start on a relatively low dose, and then we start just increasing the frequency, the intensity as we go to tolerance. And like I said, none of these dogs have been sedated for this, and they've done very, very well. And the same with my osteoarthritic patients. You just give them a little bit of incentive, and they do fantastically well. So I think that's the most important thing to just keep in mind, is to moderate it per patient as they need it. And they'll be very vocal about their response. And remember too that you're going to have different stages of healing in an area. So if you took Gus, for example, or even Bear, there was so much to heal in those cases. But some would have progressed faster than others just because of the body's ability to heal, angiogenesis, vascular integrity, all of that sort of thing. So I think that's where really getting to know your machine and your patient comes into it. And you're going to hit some really sore spots, but then move down and it may not be as intense and they may be able to tolerate it. So you've just got to be quite intuitive with the machine. That's why it's not like a one and done, oh, you do this for this patient at this intensity. I think it really does change according to your patient and the level that they're at a certain time.
I think that's very helpful. It's to tolerance. So that's very, very helpful. And that's what I think Cindy did when she explained to us in class. But my other question is, it mediates the pain, so it eliminates the pain. And are there any precautions that, I know these dogs were non-weight bearing, but for osteoarthritis or tendinopathy, they're not going to feel the pain, which is preventing them from doing some things. So after treatment, do you tell them there are precautions to be followed?
Mhm.
Because they're not going to feel the pain that's going to give them the signal, hey, I'm doing too much?
Absolutely. So I think also that we have to be careful on how we word that, because really it's pain moderation, I would like to say, opposed to complete pain inhibition. Um, so they definitely do get a fantastic endorphin response, and their dopamine levels go up, and their serotonin goes off the charts, which helps with our descending pain response, and moderating the descending pain pathway. So absolutely, I think it's really important that people understand the healing crisis. So anytime that we create a change, you are going to have a 72-hour period, which is generally what we see anesthesia as such in shockwave. It's normally is a 3-day period at a push. Is it's going through a healing reaction. So during those times, it's really important for people to moderate what is allowed at that point. And I warn repetitively, and I'm very clear in my directions for what we're going to do moving forward over the next 3 days. And I also give people the worst case scenario, because as much as we don't like to admit it, some of our treatments can cause adverse effects, whether it's just tenderness or bruising or whatever it may be. We don't. I always say when I lecture is you want to tell people before you do it, because afterwards it's always like you're kind of backtracking and you're like, oh, just by the way, and then they always wonder if you've messed up, which you haven't. But I think I have been doing this for a couple of decades now, and I've learned to rather ask forgiveness first than afterwards. So I kind of preempt it, and then if it doesn't happen, yay, everybody's a hero. But rather like give the worst case scenario beforehand. And I always say to people, you know, we are affecting the nervous system, we are affecting the cellular response system in the body and the immune system and all these things. So your dog, you know, you're going to, you or whoever we're treating, your dog is going to be tired. They may have X, Y, and Z. So I always say do that beforehand, instead of doing it afterwards. Otherwise, people always wonder if you're kind of covering your butt or not.
No, and I think with our senior arthritis cases, which we've mentioned a little bit, and it's so valuable, but we have to pick where we're going to do it each time, in my opinion, because arthritis is going to can be systemically in multiple joints.
Absolutely.
And then you have your senior with kind of a little bit of a compromised healing pathway or compromised immune system. So I have started to recommend on some of those that, you know, hey, stick to your hind end or a core area one treatment. And if they come twice a week, then maybe do it the front end a different day, or a different week. I just, you know, how much can your body heal is my question. Or I try to ask myself as I'm treating these dogs.
Pick the worst spot really is the way to go. You know, everybody wants to treat everything in one go, and that's just not a possibility. And one of the biggest things, and Pat, thanks for bringing that up because it's important. One of the things that we need to realize in these patients, especially with bone healing in long bones, and in non-union fractures, is that they have lost so much compensation. And they've got so much disuse atrophy that when they do start feeling better, we have all of that to come back from. So that's where concurrent treatment had like modalities and things like exercise therapy, underwater treadmill, um, things like that become really, really important because if you are healing something, but you're not giving it the functional foundation to stand on, you're going to end up with a lot of issues in in other areas. So, um, for example, with Gus, he's also got bilateral luxating patellas that are grade 3 out of 4. Um, and when he was going through this surgery on this whole saga on his forelimb, they decided to do a luxating patella surgery on the one leg, and it failed miserably because he did no rehab and he was non-ambulatory on the front leg. So, not the best idea in retrospective, but I mean, you know, you do what you think is right at the time. And this was before he was my patient. So, um, yeah, so I think you got to pick your battles, but also remember to treat the compensations as they come up. So especially if you have disuse of a limb, you are going to have an overcompensated contralateral limb, and that diagonal is going to be overused. So I think really addressing those at the same time is really important because otherwise you're going to end up with recurrent strain injuries and things like that because they're going to start using their bodies in a different manner.
And I think that whole process reminds us that every day, even if it's the same patient, every time they walk in the door, they're going to be slightly different. And that's where myself, I'm a technician, and I want to be able to train our technicians and everybody who sees the dogs to be able to feel and recognize the different subtle changes that can happen. It's not always going to be the affected limb being just what they need to treat. Um, and that's part of the learning curve that makes rehab an art.
Mhm. Yeah, and I would also say that especially in your osteoarthritis, you know, since we're talking about bone healing, in your osteoarthritic patients, it's very interesting. Human medicine, there's multiple studies out that actually have shown that in human medicine, majority, 80% of musculoskeletal pain comes from a myofascial source. So even though we have this osteoarthritic condition going on, most of the pain that they're actually experiencing is going to come from um, the myofascia that is compensating for the dysfunction that's happening on a structural level. So I would really encourage you to think about that when because a lot of you who are seeing osteoarthritic patients, are you like, I remember always going, I see the same pattern every time. Like I get rid of these and then a week later they come back and they've got the same stuff. And that's where it's really important to retrain the nervous system and start changing gating patterns and strength, doing different strength protocols to change the myofascia. And I think that's super important, as well as obviously addressing the myofascial dysfunctions that you're finding in practice.
Any other thoughts, questions, ideas? I think as well as dosing in terms of pulses and energy, another question that we run into or that I hear all the time is the timing of your treatments, because everybody doesn't get to see their patients every week, or some want to do it more often, some want to do it less often. So I guess my question is, I have basically backed out of that how often to treat question as much as possible, and said the most important part is to treat during the right part of the healing process. Does that make sense?
I think it does. I think what you do need to reiterate, though, is that the healing process needs to be followed. So you can't go in like you can overstimulate tissue, and we know that. So I think, to be on the safe side, if you look at all the literature and a lot of cases that have been presented, I think the standard protocol is not to go under 7 days,
Mhm.
is really the ideal. Maybe 5, depending on the level of injury. But in most cases, and particularly with bone healing, I would say 7 to 10 days is the ideal time. Because otherwise you're not giving the body the actual time to heal. You kind of assaulting it over and over, and then it becomes an assault, not a stimulation, which results in healing. And I think that's the important thing to understand is, a lot of the time, especially as a new practitioner, you want to throw as many darts at the board as you possibly can, and preferably all together, because something's got to stick. Um, but really understanding your protocols and when to use them at what times, with what modality and what system, is really important, because you can overwhelm the nervous system very quickly, and then we start having a shutdown of different systems, including your immune. And if we don't get the correct neuromuscular response and immune response, we really are hampering our patients more than we're helping them. And I think that's super important. And people need to understand the healing reaction that goes on, and how incredibly important that is to actually occur, and kind of go through that process before we hit it again.
Well, and I noticed you mentioned speeding up the healing process by 22%, which for on a scientific level, that's like a huge amount of increase in healing. But when we get the marketing and kind of the general layman's terms, they're like, we're treating this dog to increase to make it heal faster. But there's only so fast the
Be
tissue.
careful with the top, it doesn't stay on the top, but, and I'll see you tomorrow.
Thank you, Jasmine.
So I think, I guess that's another issue that I have with the whole thought process is, more is not better. And we still need to understand that speeding up healing is one thing, but it's not magic. It's not going to make it 50% faster or 90% faster. The dog's not going to be healed in 2 treatments,
Well, I think it's also creating a realistic
Goal.
expectation of your client. And that's with everything and anything is, don't overpromise and underdeliver.
Under promise.
Well, realistic, right? Like, and always have a range, because that's the thing. I mean, Gus, for example, hadn't had any healing in 6 months, and it was like, that it was a little bit touch and go at that point. And I mean, we were obviously thrilled with the outcome, but I was like, this is our Hail Mary, like this is it. So with clients really understanding that and being on board to try, I think that's that's education is key. You got to educate your clients.
The other question I ran into in recent months was, which kind of baffled me, but maybe you can help me understand it more, was if it heals non-unions, right? They're really hard to heal in bones. And then they came back to me and they said, well, I can find all the literature on non-healing bones for non-unions, but why am I shockwaving a bone post-surgery? Yet we know it's the same metabolism.
Yes, and also I think what's really important is the stimulation of those mesenchymal stem cells. I think that's super important, as well as angiogenesis and neovascularization. So the best way that you can heal anything is to promote blood flow. And you throwing in cellular components with your stem cells at that point. So the healing is going to be amplified, and it's going to heal much faster with better bone. And that's the important thing to realize, is what you're doing at that surgical site is actually you're creating a healing explosion. Like you're putting everything in there that could possibly work for this to heal faster and better with less complications. So that's the reason why we shockwave post surgery. And there's a really nice paper. I get it for you. It was done by Keeves et al. And they did TPLOs, which is a canine tibial osteotomy, basically. And it was really interesting because they did it at the time of surgery and once after that, and the outcome as far as healing at the 8-week mark was substantially better.
Yeah.
So I think,
Provide us with that?
pardon?
Can you provide us with that paper?
Yeah. For sure.
Yeah, I have that. I can post it on the users forum.
You got it?
Yeah.
Yeah, I can tell you it is Keeves and yeah, I can absolutely give that to you. It was a 2015 paper that was in the VetComp Orthopedic journal. So that's fantastic to hear, and it's not being done as a standard protocol, which is really unfortunate because we're trying to do a whole lot of things. Like in human medicine, we're putting um, mesenchymal stem cells, but not necessarily bioidentical or from the actual source. So they're not pulling your own stem cells and putting it back in your body. It's often coming from a different source. And they were putting that in at surgical points for a while, about 10, 15 years ago, they started with this, and the results were really varied. I think what the important thing to do, in my opinion, is at the point of surgery, create the body's healing reaction to be optimal. So you can create those, you can stimulate those mesenchymal stem cells for the body to create its own at that point. And the same thing with angiogenesis and neovascularization. So the more blood and the more stem cells we have, the better healing you're going to do. It's just basic physiology. Does that
Awesome.
help?
No, that's great. A better way to explain post-surgery, or yeah, acute dash post-surgical treatment is always helpful.
So the surgeon at the clinic that I did my internship is doing that. He's doing shockwave after
Awesome.
TPLS. So I find it really interesting now to see how is it working? What is it doing there? And mesenchymal stem cells is like the answer.
100%. That and vascularization. You got to remember that when the body is affected, and especially in a surgery like a TPLO, where we're actually lobbing off the head of the tibia and we're relocating it. So that's basically a non-union fracture. If you think about it it's not a long bone fracture, but it's a non-union fracture nonetheless, because we're organizing that bone. And so if you can get that to heal faster, and also, I mean, the idea of actually creating stability around the implant, I think is really important too. So, in my opinion, with the dogs that I treat in my practice, a lot of them are start getting really active at around the 6-week mark. And that's where we start seeing them regress because the owners aren't ready. Like oh, he's so great. I'm like, no, 12 weeks is tissue healing. But that's where I think the difference could come in with Shockwave is at those 6-week marks to help really vascularize that soft tissue and help to increase the integrity and the strength of that soft tissue at that point with the use of Shockwave, and then really isolating the different areas that we know are very, very susceptible in TPLOs and stifle injuries, like the gastrocnemius muscle or the sartorius, and really getting rid of those compensations at that point. I find for me, that makes a huge difference as to how successful my TPLOs are. So at the 6-week marks, I really start working on those muscular compensations with Shockwave, and they do so much better.
Yeah. Awesome. Any other questions, comments? Well, I really appreciate people making the time to come tonight, and I know it's Christmas and it's time to be on holiday, but we will have this recorded and posted on the user forum on the website. I will post that Keeves paper. I also want to put the Midamar paper up. I'll put those two up on the users board on Facebook so everybody can find them easily. And I appreciate your time and energy, and thank you, Michelle. It's always great to hear from you and to learn more on every occasion. And have a great holiday, everybody.
Thank you very, very, very much. It was a very, very informative.
Thanks, Dr. Mike.
Thank you so much.
I'll be using it on my leg tomorrow.
Good plan.
I saw that X-ray due every week. Every week.
Merry Christmas, everybody.
Merry Christmas.
you.
Thank you very much, Cindy.
Take care. Thank you.